So this study found that HNF1 alpha was important in the particular aspect of glycosylation, which is adding fucose groups, so fucosylation. And this is through regulation of production of GDP fucose. And the story gets even more complicated at this point because it's a particular type of fucosylation that's affected. So I've tried to draw this out if I can. So the sugars are added in long chains, and they're called antennary fucosylation. And it's when you add a fucose group onto these antennary fucosylated substances rather than the core ones at the bottom. And this is the process that HNF1 alpha seems to be particularly involved in. And as I say, it's complicated, but I think the take-home message is that there's a particular kind of glycosylation that we can look at, which is most affected by HNF1 alpha. And you can make a ratio of the antennary fucosylation compared to the core fucosylation. And if you do that, well, hang on, let's just step back a second. So we again hypothesised that HNF1 alpha mutations may affect this process, and looked at this in our MODY subjects with HNF1 alpha, glucokinase, HNF4 alpha, type 1 and type 2. And glycan profile is measured by HPLC, and it can only be measured in very specialised labs through collaboration we've got in Croatia and Dublin. And this shows several alterations to the glycan profile, but it's mainly related to this antennary fucosylation. And so all of the differences we saw were related to decreased antennary fucosylation in HNF1 alpha MODY. And this just shows, this is sort of dot plots of the distribution of a particular measure of antennary fucosylation. So we've got the types of diabetes along the bottom and this ratio at the side. And I guess just the take-home message is that if you look at the HNF1 alpha cases, the values are very much lower and tightly grouped compared to the other kinds of diabetes and also healthy controls. So there is a substantial difference, and this is very significant. There's a very small p-value, and again, does that translate into discriminative accuracy? If you look at the ROC curves, then they do seem to differentiate very nicely from HNF1 alpha MODY for type 2, type 1, and against healthy controls. So what's nice about this is it seems to differentiate both type 1 and type 2 to a similar degree. And as I said, the problem we've had before is we've never had a biomarker that you could use in type 1 diabetes very easily that was specific. So again, this is still work in progress. We've got to do a lot more work on looking at this in other data sets, but it seems very promising. I would say the major disadvantage of this compared to something like CRP is the complexity and difficulty in measurement. So although it might end up being a better discriminator, whether we can actually move that into clinical translation any time soon, is a little uncertain at present. So if we're looking for, just to go through what the process is of looking for developing a biomarker from sort of bench to bedside. So you derive the candidate biomarkers by the method I've talked about, and obviously do initial testing in case control studies and replication studies. This is sort of the phase that we're at now with these biomarker studies that I've described. But it's really the validation in the diagnostic setting that's going to be the crucial thing in terms of actually making a difference to diagnosing more patients with MODY. And that obviously is going to involve wide-scale clinical use, but also things like commercial development, if we're talking about the glycan profiles, health economic evaluation, and all those things that are important in developing a new laboratory test. So we're still a little way from actually using these things as an everyday test. So just to conclude, we've recently described promising biomarkers for common MODY subtypes, and feel that the best use of these will be added into clinical diagnostic algorithms along with clinical features to to allow a more systematic approach to identify monogenic diabetes, hopefully near to diagnosis. And at the moment, we're working hard on trying to translate this into clinical practice, but we will need outcome data and things like health economic analysis to support the wide-scale use of these things. Thank you.
Thank you very much. Katrin, thanks a lot, and I think that neither I exaggerated saying that it was going to be edge-cutting research, neither I was disappointing. Thank you very much. And we have 2-3 minutes for questions. Sandra.
Those are really nice data and very promising. Now, one important thing to understand how this is improving discrimination is to know where we start from. So what is the ROC of just a simple clinical features like, autosomal dominant heritage, inheritance, and young age diagnosis? So in other words, we don't start from 0.5.
No,
we start perhaps from 0.7 or 0.75. Yes. So I wanted to know whether you have a figure for that on which you are adding with a marker.
I'm not sure off the top of my head that I have that figure, but what we've looked at are the sensitivities or specificity figures. And we know that if you use clinical criteria, the classic clinical criteria like age of onset under 25 with a family history, that's actually quite a specific test because there aren't many people with type 2 who fit those criteria. So it's over 90% specific, but it only picks up about half, 50 to 60% of your cases. So it's not performing well from that point of view. And similarly, we looked at some of those other clinical features when we were looking at the CRP paper, and it's hard to remember the exact figures off the top of my head, but they performed, if you sort of take age of diagnosis under 30 just on its own, it performs similarly to CRP. And if you put the clinical features together with the biomarker, you get a bit more. I mean, I think we're talking about with CRP that we're going to be picking out 20 to 25% of people with type 2 and finding about 80 to 90% of the MODY cases. But I don't know what the ROC figures are.
Do you have any experience in using alternative methods to evaluate the discrimination, like reclassification indices or other? I mean, probably in this case, you don't need those, but I was wondering whether you are exploring other ways of expressing the performance.
We haven't, but if you can talk to me about it afterwards, because obviously we'd like to look at these as thoroughly as possible.
Questions? Katrin, most of those people here sitting in this audience are practicing clinicians. They are going to come back on Monday to their clinic. So, what message are we sending to them? Should they start using CRP in the practical work already?
Well, I think this probably has to be led by the local diagnostic testing centres, who will have presumably local recommendations for samples. I mean, I think one problem at the moment is because different assays give you different thresholds, different cut-offs, it's hard to say, yes, you should test everybody whose CRP is less than, a certain amount. And we certainly found, when we're comparing assays, and have time to go into it, that the assay that we've been using in Oxford, which has a very low reporting range, is actually the better discriminator, because obviously, because of the way that the HNF1 alpha samples cluster, they get a lower value in that assay and there's a bigger difference from the type 2 samples than the other assays. So I think you've got to be a little bit careful about what assay is used, and at the moment, I think we have to get together as a sort of diagnostic testing community and actually produce guidelines for this, and that's certainly something we should probably be talking about this year.
Okay. Kasia?
Thank you for a nice presentation. I just wonder, because measurement of CRP and alpha-glucosidol, it sounds very nice for diagnosis MODY subtypes during pregnancy. So I wonder, do you have any experience with that time? Can we speculate that we can use these cheap and quick tools for diagnosis of MODY subtypes during pregnancy?
I mean, I don't know what happens to CRP during pregnancy as a general thing. I mean, does it go up? Is it normal? I don't know. I mean, I guess there's data around. And I think with all these extra groups, like, can we use it in children? Can we use it in people from South Asian origin? Can we use it in pregnancy? And all these things will have to be looked at and consider what happens to CRP in the condition anyway. What's your main differential? I mean, I don't see why not. If you can sort of demonstrate that CRP is, I mean, if CRP does go up in pregnancy, it actually might still discriminate quite well if it doesn't go up, particularly in the HNF1 alpha cases. But again, we're not quite sure what happens to CRP in people with HNF1 alpha who have inflammation, and that's something we're trying to do a study on. I mean, we have a couple of patients who have HNF1 alpha mutations who also have evidence of insulin resistance. So they're kind of a mixed phenotype. And they do have higher CRPs than the sort of more classical HNF1 alpha. So this test might be best at picking out your classical cases. So, I mean, I say potentially, but I don't have the data to really back it up.
Okay, thank you very much. And
I'm not based in